Hello, I'm Natalie Host, and I'm here with DePaul University Professor Dr. Craig Klugman. Dr. Klugman has been a health sciences professor at DePaul since 2013 and has been serving on DePaul's COVID-19 task force during the pandemic. Dr. Klugman, thank you so much for taking the time to do this interview.
My pleasure.
So first things first, you are a member of the COVID-19 task force for DePaul. As an academic, have you been in very many situations like this one where you've been able to apply your expertise towards a direct vote on policies that will affect the entire community? And what's that like for you?
Yeah, I mean, I think my work is in the area of bioethics. And so one of the hallmarks is that we are very applied. So, you know, the reason that I was chosen to be part of this group here at DePaul is because I had led the state of Illinois crisis standards of care ethics subcommittee, was part of their main group. I've done this with the state of Texas. I've done this with the borough of Brooklyn in New York City. So I have a lot of experience on sort of pandemic planning. I also do clinical ethics at Northwestern Memorial Hospital. So, you know, being able to do my academics in the real world settings is sort of a hallmark of the bioethics enterprise. So that's been really exciting. I think it's been fantastic for the classroom as well, because I can show the students in real time why what they're studying is valuable and why it is important for making decisions in their lives, as well as different professional roles they may choose in the future.
Awesome. So when conversations kind of began regarding the return to in-person classes at DePaul, what were your initial reactions, and like what specific concerns did you have for yourself and or the students?
Well, I mean, my main concern is that everybody remain healthy and safe. And, you know, from the beginning of the pandemic, that's really been the operating mission and virtue of the university is, are we keeping people safe? And so, you know, my initial thing was, can we do this safely? What are the things we need to do to mitigate in order to make it safe for us to return? And so we were looking at things like, you know, masking, we were looking at hand sanitizing, we were looking at cleaning schedules, we were looking at elevators. We spend so much time on elevators because, you know, we have these lovely towers in the loop, but some of them are old and some of them are small. And so how many people can you have in there? How long will they be there? What is safe? And so sort of every aspect of the student, faculty, and staff experience, we looked at, see how it could become safer and what we needed to do. And so, you know, it became very clear very early on that we needed, once that day became available, that vaccines were going to be a really key part of any response. We look at it as sort of slices of Swiss cheese, and everything you could do, from a vaccine to a booster to masking to hand washing, they're slices of cheese. And the goal is to make sure that in this whole block of cheese you have, that none of the holes line up. So you want to have at least have a block of every place. So that's the metaphor that's used. So those are the sorts of things we've been working on. We've also been concerned about, you know, the impact that remote learning has been having on the mental health of our faculty and our staff and our students. And how do we make sure that we engage people? So it's sort of safety while we can still do the work of the university, of educating, of research, of serving our community. And it's often a very tough balance to maintain.
Yeah, for sure. So in the last couple of weeks, DePaul instituted some new policies regarding this current phase of the pandemic. In particular, a requirement for staff and students to receive not only a booster, but also to wear N95 or KN95 masks on campus. So how do you feel DePaul has adjusted its response to the virus as the science and case numbers have changed and evolved?
I think we've done a good job in keeping track of the science. We have people who meet with the city all the time. We have a community health team that is part of the response task force. I am a member of that meets at least every other week, sometimes every week, when we discuss what's the latest guidance, what's the latest science, what are the issues that we are facing at the university. We get requests by certain departments who maybe want to have a performance or want to have a camp, and what measures can they take to bring people together safely. So those are the sorts of things that we're looking at. And when Omicron appeared, which was after fall quarter, so we were already in our winter break, And suddenly it was like, wait a second, we've got this break and this thing's happening fast and we need to respond. So we looked at everything that was happening. We looked at WHO and CDC. We looked at what was going on in South Africa and in the UK, which were sort of the places that got hit first. And boosters came out of some very early work done in Israel that they found people with boosters had a more robust immune response and lower rates of infection, that over time that you had waning, meaning that you had fewer antibodies available to attack the virus if you were exposed. And so we realized that that would be a necessary step on this. We also looked at masks, and studies were showing Omicron is more infectious. It is easier to catch. It looks like in any given volume of air, there's just more virus around. And so, whereas earlier variants had been on particulate matter, so they stuck to globules. If you sneeze, they were on those large globules. And so things like a cloth mask would prevent that from passing into the air. Omicron is seems to be more airborne. And so a cloth mask isn't necessarily very helpful. And again, with that eye of trying to keep us all safe, we realized that we needed to up our mask game. It also we announced that days before the CDC came out with their requests and recommendations for better masking. So, in some ways we are leading. We were one of the first to go online in summer of 2020 to say we were going to not be opening. We were one of the first to say we're going to do 2 weeks of winter quarter in person. We were one of the first to have a vaccine mandate. And in other places, we are also following what our local schools are doing and other Catholic universities throughout the country are doing, again, in the attempt to make people safe. We have the additional challenge in COVID response in that we are located in one of the largest cities in the country. And so it's not just what's happening on campus. We also have to look at what's happening in our community.
For sure. And then as we continue to move forward, is there anything that we can expect to know for certain regarding future variants, and how does a task force like DePaul's approach the element of the unknown, like future variants?
We keep in contact. So we may only have formal meetings, every other week, but we have a Teams thread where we're constantly changing information. We have email exchanges all the time. So, we are in constant contact with one another and sharing what is going on, the latest guidance, latest science. What can we expect? We don't know. That we have to be facile, that we have to adapt, that we have to improvise. We don't know what will come next. There's predictions that this may become endemic. So it'd be more like flu, and we'll probably have an annual vaccine that we have to take based on whatever the current variant is. Until we have the entire world, and not just the US, the entire world vaccinated, then there will be variants. Some like Omicron will be spread more easily, but maybe not be as dangerous to health. Others might be more dangerous to health. It's really, we're watching evolution in action here as we see these variants come up. So the one thing we know is that things will change. They will change fairly quickly, and we have to be adaptable. But we've also shown that we can go online at a moment's notice. We can have hybrid classes. We can have flex classes. Like, we've gotten very good as faculty to adjust to the need of our students and what is going on in the pandemic. There's a cost. There is definitely a cost for social and mental health. But, I think we're doing a great job.
Awesome. And then moving in a different direction, you describe yourself as a bioethicist and a health humanist. The phrase health humanist in particular is a little bit redundant to me, I guess, in the sense of how do you separate health from humanity?
Sure.
And what do those two labels mean to you?
Absolutely. So bioethics is the study of moral issues in the life sciences. And so my particular area is public health ethics. So how do we make decisions for populations? Pandemic's perfect example of that. But, it really came about in the early 1970s when we started developing new technologies like ventilators, and we could keep people alive and we could do things to bodies that we couldn't do before. It was also part of the patients' rights movement. In the middle part of the 20th century, doctors made decisions for you. You didn't have decisions to make. The doctor would say you do this and you did it. And so there were a bunch of things happening in the early 1970s that led to the evolution of this area of bioethics. And so we look at all sorts of issues about end of life, beginning of life, professionalism, and now many of us have moved into the arena of public health. So it's really about making these tough choices, these dilemmas, and how do we work through them, which is part of the work that I do at the hospital. It's part of the work that I teach in my classes. And then the health humanities is actually just as old as bioethics. And it came out of the fact that since 1910, in medical schools, we teach science. And the prerequisites to get into medical school are all science. And what happens is that those med students don't have as much of a liberal arts background. They don't have as much exposure to the humanities. We have seen, lots of issues in regards to communication, empathy, with connecting with their patients. And so the humanities have been brought in as one way to deal with this. So when we talk about medical or health humanities, we started with bringing humanities classes into medical schools. So, for example, I taught, when I was at a medical school in Texas, I brought in an arts program. So we took medical and nursing students to an art museum, and we taught them observation and teamwork skills by looking at art. There's narrative writing, narrative medicine, where we teach reading and writing literature as a way to be able to develop communication skills and observation skills and reflection, and be able to tap into your own experiences and feelings when being a care provider. And so in health humanities, we're taking it out of the med school and we're putting it into nursing and PT and OT in the undergraduate program. And since 2001, we've gone from 15 to 122 undergraduate health humanities programs throughout the United States. And the theory is that the students who have this sort of humanities related to health and medicine, where they're still doing literature and they're still doing art and they're still doing philosophy, but it's related to health and illness, that they are better prepared to be our health professionals, to be more resilient and to connect better with patients to help them. So that's really what the health humanities is it's using the humanities to help healers be better healers, to connect better with their patients. It's also useful for patients in order to think about their own experience and to cope with the illness that they have, as well as for the healthcare worker and for the students. So they've become very popular programs and they're continuing to grow immensely every year. So, the health humanities that I do at DePaul is I teach a class in health humanities where students learn how to engage with literature and with film and with poetry. They create art, they create comics, they learn how to engage with people who are patients in the community in order to do these things and to tell their story. And really, it's about storytelling, about narrating, and about witnessing people's experiences in illness.
I think that's very important because it teaches you, I guess, a sort of empathy.
That's the hope. That's the hope, that it's more about it's less about being a technician and more about being a healer. We know from studies that, if how your physician talks to you, how your nurse treats you, those are the most important parts of healing, is that connection and that sense that somebody's caring about you. And, so it's really about the human skills that are needed to truly be a healer.
Right, exactly. So the common stereotype of a scientist is someone who is super efficient and views things as like black and white, I guess. Mm-hmm. Someone who spends a lot of time evaluating philosophical questions and are often stereotyped as, spacey or absent-minded. And your chosen path suggests that you might be a bit of both or neither. How do you square that seeming contradiction in your life as a bioethicist?
Well, I'm not trained as a scientist, right? I'm not a bench scientist, so I don't know that I see that as part of me. I came to this work after being a journalist, a tech journalist for many years, as well as a performer. So, the skills that I bring are about communicating and about connecting with people. And it was only after those careers that I decided to go to graduate school and get my master's and my PhD. So I don't see myself in any of those descriptions. I think, what somebody who does health humanities or bioethics does is about being applied. I'm far less theoretical than most people in philosophy. I'm interested in the specific case, not the sort of bigger theoretical question. I'm interested in engaging with people, communicating with the public, making sure that students see the application for what we are learning. And so, and I think a lot of science has moved in that direction too. One of the programs that I help run at DePaul is called the Op-Ed Project, where we teach faculty and staff how to write op-eds for media outlets, how to share what they know as experts through their years of study and research and teaching with the larger community. And it's been a highly successful program. People really want to get in. We usually have a waiting list for people to get into this. And I think really what this is, it's about drawing connections between the community, between the public, and between the university personnel, so that we can show the practical value of what we're doing. That this isn't just, the ivory tower on the hill, that we are addressing questions that plague our current, sorry, no pun intended with plague, our current reality. And we're coming up with solutions. And we're working with our community partners, with the public at large to do this. One of the things I do is I serve on a board for the U.S. Department of Health and Human Services called the National Biosecurity Science Board. And we are coming up with recommendations on how do we respond to biothreats. We just released a piece on sort of the strategic planning for health and human services in the next 5 years. So again, that is another way that I'm applying my academic work, my scholarly work, to helping the society by serving as part of the U.S. government.
Awesome. Along with the topic of COVID, in a pre-COVID world, what were some of the science or health-related crises of ethics that you studied?
So I've been working on sort of pandemic issues for, at least the last 12 years. So that's been a big part of what I do. But I've also done a lot of work on end-of-life issues. So how do we make decisions regarding how people are going to die? How do we give them control and, say, autonomy over their own decisions? I did a lot of work on advanced directives, which are sets of documents we make to let people know our choices at the end of life medical care when we are no longer able to make them. So I actually teach a death and dying class at DePaul, which is a very popular course where we teach people all about the process of dying, from what people die from, to what happens as the body's shutting down, to how do we dispose of bodies, or how decay works, funerary rites and rituals, completing these funeral planning, writing your own obituary, all sorts of things. So death and dying has been a big part. And then I've also done work in digital medicine. So we are in a world that the digital world is changing things a lot. People are tracking their health with devices. And so I've consulted with pharmaceutical companies. I've taught this in my classes, written papers on this. What are the challenges? There's a lot with privacy. There's a lot with the physician-patient relationship. How do you relate to your physician when there's this intermediary and there you've got an AI or the system, or when the doctor can check on you at any time to see what your current issues are? And so how does that change not only our relationships, but what are the challenges that we have as a society, and with making medicine such a central piece of our world? So digital medicine is an area that I've been doing a lot of work in as well. And then education. I actually do a lot of research into how do we teach ethics and humanities to future generations, to the students? What are the best practices? I help other universities to set up their own humanities programs, health humanities, so that they can get them going and give students the benefit of what we're offering. So yeah, it is kind of funny to think back to the life before COVID, which has been so consuming my life for the last 2 years. But yes, did quite a bit of work before that.
It's very interesting. So when you think about these different issues that you've studied and considered, what do you think unites them, and where can the world be better as it pertains to health?
So what kind of unites everything that I've done is it's about communicating complicated concepts to everybody, whether that be science, the choices at the end of life, whether that be how do people use and navigate these new technologies, whether that be how do you decide what mask you should wear. They're all about taking very complicated, very important things and making it accessible to everybody. So I think that's one of the things that sort of brings everything together, which comes back from my background of being a journalist and being a performer, is, how do you tell a good story that moves people? And I think that's a big part of it. And I think I missed the second half of your question.
The second half was, where can the world be better as it pertains to health?
Where can the world be better as it pertains to health? Health is kind of a funny thing, and we have this sense in the United States that health is a very individual thing. It's the food I consume. It's the exercise I choose to get or not get. It's about my choices, but really, health is a communal enterprise. And health is about the quality of your air and water. It's about the opportunities to get outside and to interact in nature. It's about the safety to be able to walk around your neighborhood. It's about having healthy food that's affordable and available close to you. And these are not things that you can individually decide. We've seen this in COVID. The greatest risk factors are your socioeconomics, your race, your education level. Those aren't things that we can necessarily, have individual responsibility for. So I think the best thing we could do is realize that we are not just responsible, we are responsible for the health of everyone. We are responsible for the health of our entire community. And we have to think about health in terms of overcoming structural racism, overcoming the barriers that as a society we've put in place for people to live healthy lives. And that we have to do it together, right? A virus shows that, it doesn't matter what neighborhood you're in or what state you're in, the boundaries are meaningless when it comes to health and when it comes to infection and illness. We are all in this together. So we have to deal with it together.
How do you feel that your specific work and point of view fits with DePaul's Vincentian ethos?
My reading of the Vincentian values and the mission of the university is that we are here to, improve our community and our world through education. And by focusing on social determinants of health, by focusing on how to allow people to think about issues that they may not be aware of, to learn how to think critically, to read critically, to write and speak critically. I think I'm empowering people to make better decisions. One of the things I say in bioethics is that there's no right or wrong. There's better and worse. There's the reasons you can have for what you think and what you believe and how you act. But it's how do you find those reasons? How do you find good resources? We are awash in misinformation. And so one of the things I concentrate on in my classes is finding good sources of information, of reading them critically, thinking for yourself. And I think it's about becoming an engaged citizen of the world. It's actually a phrase I use in my classes. That what a good liberal arts education does is make you an engaged citizen of the world. And if you look at the many learning outcomes that we want our DePaul students to have, it's about engaging the community, it's about being healthy people, it's about being ethical people, it's connecting with your community. Those are all the things that I'm working on and offering through my courses.
It's a good thing to offer.
I think so.
And then finally, what has been the biggest learning experience for you in these last 2 years?
I think as a faculty member, we have this sense that we do our work and it's really kind of separate from everybody else and everything going on at the university. I teach my classes. It may be in a sequence of courses that students take. I do my research, I do some presentations, some papers. But the biggest thing has been seeing the university from the 30,000 foot view. If you're on an airplane flying over, having worked on things like HVAC systems for the dorms and what's, airflow and elevator safety, and learning about our public safety people who never had the opportunity to work from home. They were always on campus. For me, the biggest learning experience has been learning about the university as its full self instead of just my little piece of it. And that's been eye-opening. I've learned that, institutions move slowly, that, you can't just say, okay, the world's changed, let's change. You have to lead people. You have to inspire people. And so I think that's been a big part of what I have learned over the last 2 years is in providing guidance and providing content expertise is how do you move people, change their behavior, change their thinking in a large organization that moves slowly because that's what large organizations do.
Well, awesome. So thank you so much for your time today. It has been an absolute pleasure. This has been Dr. Greg Klugman on DePaul's COVID task force. I would like to remind everyone to stay safe, stay healthy, and to do your part.
Get vaccinated and wear masks. Thank you.
Yes.